Okay, sorry about that, guys. We're having some AV issues. But we're going to go ahead and get started. You might hear a few beeps that come in. We're trying to work on that. IT is working on that now. For today's trauma lecture series, we have one of Denver Health's OBGYN physicians, Dr. Nicki Nguyen, and today she'll be presenting on the obstetric trauma patient.
Okay. Hello, can you all hear me? You can hear me with this? Okay, great. Thank you so much for having me today. And so I am just a generalist in our OBGYN department, and I think one of the main reasons that I was invited here today is for some reason my name has come across a lot of the OB trauma patients, whether you look at that in a fortuitous way or not. But I have no financial disclosures. And how did I get here? So the main reason I feel like I'm here is because of this big dark cloud. It feels like anytime I'm on call covering L&D, this trauma phone just goes off. And so because of that, I have fortunately or unfortunately been able to really take care of some OB patients in major and minor traumas. And, you know, I didn't do a critical care fellowship or anything like that, but most of this is just kind of my own experience and my training and working at level 1 trauma centers. So I just wanted to review with you today the objectives. And I do want to say I am recovering from a cold, so if at some point I start coughing, I apologize for that. So I just wanted to touch base and review some of the changes of maternal anatomy and physiology changes. We're not going to go into detail too much about this, but just the little things that can affect as you're taking care of this patient in a trauma setting. And then the initial assessment of the OB patient after a trauma, and usually this is going to be part of the secondary survey. And this is always kind of the big caveat is the perimortem C-section, and when are we going to deliver this patient, whether the delivery is indicated, and in what setting are we going to perform the C-section. And then at the end, I just want to kind of review some of the indications for maternal and fetal surveillance, whether it be after major or minor traumas, but also, you know, we get a lot of consults on patients that you all are going to be doing a procedure on, and what is the indication for monitoring. So what's the scope of trauma in pregnancy? It is one of the leading causes of non-obstetrical maternal deaths. Unfortunately, overdose and suicide are the top 2 leading causes of OB-associated deaths, but not necessarily related. And so trauma affects about 1 in 12 pregnancies. And we know that about 4 trauma-related hospitalizations occur per 1,000 pregnancies. About 2/3 of these are due to motor vehicle accidents. And then the other third are due to falls and domestic violence. So just a quick review of maternal anatomy and physiology changes. So in the non-pregnant uterus, it ranges from anywhere about 6 to 10 centimeters, and we equate centimeters to weeks in our OB language, and so that's kind of why you'll hear that. And usually the uterus weighs only about 60 grams, and in a nulliparous patient or patients that have never been pregnant before, it's about 6 centimeters and then gets larger in patients who've had babies. And in the pregnant state, the uterus grows up to about 1,100 grams. Most of this, or really all of this, is due to muscle hypertrophy. So in the uterus itself, the myometrium, it just hypertrophies and it doesn't actually proliferate. And because of this weight of the uterus, you can get compression of the IVC and the pelvic veins. This leads to some of the vascular changes in pregnancy. And so the uterine artery is it is one of the branches off of the anterior branch of the internal iliac artery, and it crosses over the ureter about 2 centimeters lateral to the cervix, and this will become significant later when we talk about hysterectomies. But the other thing is you'll notice that the ovarian artery, it is a direct branch of the aorta, and in the non-pregnant state, it's about 0.9 centimeters, but in patients that are close to term, it reaches to over 2.5 centimeters. So if you can imagine, if you had an injury to that vessel, how significant and how rapid that blood loss can be. So I'm sure we've all seen this, you know, either from our sisters, wives, friends, along the gestational age, how big the baby is and what fruit or, nut it is close to. The main reason I wanted to show you this is because based on the gestational age, that's going to help you figure out, who's at higher risk of an injury during a trauma. Is it going to be baby or mom? And notice as the fetus grows, right, anything that's along the abdominal wall, the fetus is going to have a higher risk of injury, whereas earlier on, mom is going to have a higher risk of a visceral injury. And usually in the first trimester, a fetal loss is pretty rare. And I know we always kind of think about miscarriages as something that occur pretty frequently, but when you're looking at traumas, it's actually rare. So what are some of the changes in OB physiology? So we do know that there's about a 40% increase in the blood volume. However, the red blood cell mass that actually increases isn't 1-to-1. And so you get about a 25% increase in the red blood cell volume. And so all pregnant women come with a relative anemia. And so what's normal for a pregnant woman in her hematocrit is about 31 to 35. But keep in mind, because of this increase in the blood volume, mom may lose up to 1,500 cc's of blood and still be hemodynamically stable. However, the fetus may be in shock. And there are also some hypercoagulable changes in the pregnant patient because estrogen stimulates procoagulant factors in the liver. And because of the compression of the veins by the uterus, I don't know if some of you are familiar with this Maternal Anatomy, but because of that, the right the right common iliac artery crosses over the left iliac vein, and with the addition of the uterus laying on top of your left iliac vein, you'll more likely find DVTs associated with the left lower extremity. And this will also kind of, with positioning in mom during a trauma setting, we also like left lateral tilt. So there are multiple different types of traumas that patients can come in with. And based on the type of trauma, that's going to kind of help you figure out, what are some things higher on the differential for, either mom having an injury or baby having an injury. So with the blunt abdominal traumas, a lot of the times it's going to be, mom's going to look completely fine, and this is where you really need to do rapid assessment of baby. And penetrating trauma, depending on how pregnant the patient is, the pregnant uterus is, acts as a protective factor for the viscera of mom. And so fetuses, as the gestational age progresses, are more likely to be injured. And we also have these deceleration injuries, and these are the ones that we normally see in motor vehicle accidents. So if you can imagine, it's the same thing as the contra coup phenomenon, and you'll normally see, if you are going to see anything, it's going to be a placental abruption. And in rare cases, you can see a uterine rupture. And in women that have pelvic fractures, just due to the way that the maternal anatomy is, pregnant women may be at higher risk of retroperitoneal bleeding. So that's something that you just always have to keep in the back of your mind. If you seem that you've ruled out a placental abruption, there's no evidence of intra-abdominal bleeding, then she may have a retroperitoneal bleed. And keep in mind, for pelvic fractures, it's a rare case scenario that these women can't have a vaginal delivery. Most of the women are fine unless she's having to deliver vaginally soon after her pelvic fracture, and she can't be put in lithotomy position. So what's the initial assessment of the OB patient after a trauma? So I can't stress this enough. The maternal management is the first priority because mom's survival truly dictates fetal survival. And I'm definitely not here to tell you how to do a primary trauma survey because you all are definitely well versed in that. But once you have secured her airway, stabilized her spine, the biggest thing that we would like you to just remember in the pregnant patient is to try to do a left lateral tilt. And if you'll notice here, the reason when mom lays flat, she's compressing her IVC, and so you're reducing your preload to the heart. And just even a left lateral tilt, 20, 30 degrees, she can still be on, I'm having a loss for words of what that tray is that the patients are on in trauma, the backboard. You can lean that underneath, and that's going to help the mom just kind of get more blood flow to the baby. And keep in mind that all indicated imaging should occur. So you should really treat mom in the primary survey like you would a non-pregnant patient. And there is an emergent imaging in pregnancy in our policy stat if you want to just review that. So again, the pregnancy should not alter any necessary treatment. In the secondary survey, if the patient is awake, please just ask her how far along she is. That's going to be the quickest way to figure out, is this patient viable or not? if she, for some reason, is incoherent or has loss of consciousness, you want to assess the uterine size. If the uterus is anywhere near the umbilicus or above, then that gives you a sense that she may be viable. And feel the uterus. If it feels rigid or tender, that could be an early sign of an abruption or labor. And so we always, say to try to do a vaginal exam. I know not everybody's going to be able to say this patient is 1 centimeter or 4 centimeters, but the biggest thing is even just on your vaginal exam, you might not be able to feel the cervix, but do you see any bleeding? And if you do see bleeding, that is going to increase your likelihood that you might have an abruption or she might be laboring. So in the fetal evaluation, the rapid ultrasound is going to be the easiest way. Most of you guys are going to be doing a fast scan anyway, and so if you have an obstetrician there, and if you don't, there are going to be some numbers that I really want you to take note of, and it's going to be the 24 weeks viability, and the BPD, or the biparietal diameter, of 6 centimeters or more, or a femoral length of 4.4 centimeters more. So if there's any two numbers you take away with you, this is what I would write down. Okay, and again, the assessment for placenta abruption, and this is going to be a clinical assessment. The really only thing that you're going to need to help you from a diagnosis standpoint, from a lab value, is going to be to diagnose DIC. But I did want to kind of talk a little bit more about the ultrasound findings in case you don't have an obstetrician nearby. So the biparietal diameter, it's the widest transverse diameter of the fetal head. And keep in mind, the fetal head is somewhat ovoid, and the best way to make sure that you get it is that you can kind of see the thalamus within the cross-section. And you're going to measure from outside to inside. And if that is 6 centimeters or more, that's likely that the fetus is about 24 weeks or higher, and that gives you viability. The other is going to be the femoral length. And the femoral length is definitely harder to find than your BPD. So with the femoral length, you measure it from the blunt end to the blunt end parallel along with the shaft. And so you're not going to measure at these points here. You're really going to try to get just right at the midpoint. And 4.4 centimeters or more is going to give you a viable fetus. Now keep in mind, the reason that we kind of stress this is because you don't want to do an urgent C-section on a pre-viable patient. And we have definitely, these measurements alone have helped us from crashing a patient that's 19, 20 weeks, just given, because sometimes our patients have a larger body habitus and it's hard to tell exactly where their umbilicus or their uterus is. So what are the roles of specialists? So in the optimal setting, luckily here we're at a level 1 trauma center, so all the patients that I see are in the ED. And so we definitely defer to our trauma surgeons and our emergency department to do the primary survey and stabilize the patient. Once you feel that the patient is stable enough for us to do our assessment, we are really looking for these 3 things. Is the patient in labor? Are there any signs of a clinical placental abruption or a uterine rupture? So the rapid fetal assessment and gestational age is part of that secondary survey that can be done pretty quickly. And this is where we're going to determine if the C-section is needed or not. So what are the indications for delivery? And we're going to discuss the resuscitative hysterectomy. And, this is kind of a new term that some OBGYNs have kind of tried to put into use because it really does kind of tell you that this is really for maternal indications, because normally by the time you're at a point where you can even do a C-section, whatever insult the baby has been exposed to has already happened, and you rarely change the fetal outcome. So from perimortem C-section to resuscitative hysterectomy. So these are essentially the same procedure. However, keep in mind that the perimortem C-section or resuscitative hysterectomy is really for maternal indications. And the traditional thinking has been that you do the perimortem C-section if mom has gone into asystole and you've performed CPR for at least 4 minutes. And if she doesn't improve in that time period, you perform the C-section. Now keep in mind, studies have shown that this is extremely hard to do. Even when you have witnessed asystole in the emergency room, that 4-minute time window, all of you have been in some type of trauma, is very difficult to attain. But the reason for this procedure is that when you empty the uterus, it improves maternal survival. Because close to term, the uterine blood flow is about 600 milliliters per minute. And the large uterus also includes the vena cava, and it restricts blood return to the heart. So when you can empty the uterus, that uterus contracts, and all that blood flow that was going to the uterus is now diverted back to mom. Again, this is very difficult to achieve, and really this is the only indication to ever do a C-section in the ED or anywhere that's not the operating room. And again, that's for maternal asystole. So indications for immediate C-section, and these are the C-sections that I'm talking about that should occur in the operating room. The reason, again, is to empty the uterus and allow access to, for our trauma surgeons to really survey the upper abdomen to look for any injuries. Severe fetal distress is also another reason to deliver the patient. And again, this is only after the maternal condition allows for this. And this is typically when you are concerned for an abruption, and that's normally seen via the fetal heart tones. A dead fetus is not an indication for C-section because you can actually increase maternal morbidity and mortality based on this. And usually, if you have a 23-week fetus, we do not offer the C-section because, again, that increases maternal risk. And only would we do it in that perimortem resuscitative hysterectomy setting in which you're trying to help mom. And again, really, here, the traumas that I've been in, it's taken us less than 5 minutes to get mom up to the operating room and delivered. And so really, this should occur in the OR. That way, if you have any other injuries in the upper abdomen, chest, you have your anesthesiologist there, and you're really increasing maternal survival. So where does most of the fetal neonatal mortality occur? So maternal death is the most common cause, and that seems to be obvious, right? Below that is going to be placental abruption, and it is responsible for about 50% of the losses, either in immediate or delayed. Direct fetal injury occurs in less than 1% of the traumas, and those are usually due to penetrating wounds or blunt traumas. And normally the blunt traumas are due to if mom is driving, the steering wheel hits her, or she gets crushed within a vehicle or a fall. And keep in mind, and a lot of the blunt traumas, when you do an exam on mom, she normally looks fine. Most of the times you never see any ecchymosis, bruising, scratches, cuts, unless it's a penetrating trauma. And uterine rupture, thankfully, is rare, but can occur in really major traumas. And the preterm birth rates are 2 to 10 times more likely in major traumas. And so that's the reason why we really want to be sure that we have a clinical diagnosis and are trying to save baby in addition to mom. So 40 to 50% of the neonatal deaths occur after the major trauma. So these are mostly head traumas, emergency laparotomies, and when patients are in shock. With minor traumas, it's only associated with about 1% loss. And so the first trimester trauma really rarely causes a loss, to be honest. We think that this normally happens a lot because the first trimester seems to be the most sensitive time period, but when you think about it, the pelvis or the uterus is still rather small and it's protected by the bony pelvis, and because of that, most patients tend to do well in the first trimester. And therefore, the risk increases with gestational age just because of the protruding abdomen. So placenta abruption following a trauma is usually apparent. So most of the times you're going to see vaginal bleeding and mom's going to have contractions. And the other major sign is that if you can get the fetal heart tones on, you will see that the baby has either recurrent late D cells or terminal bradycardia. This is rare in minor traumas, but can be up to 5%. And so keep in mind that ultrasounds, KBs or Kleihauer-Betke studies, and coagulation studies are not predictive enough for a placental abruption. It really is a clinical diagnosis. And you just have to have a high clinical suspicion, especially based on what type of MVA or trauma the patient's been in. So really the role of a Kleihauer-Betke, it's not to rule out an abruption, and it's not used to determine whether you should give RhoGAM in Rh-negative patients. It is used to determine the dose, because whenever you give a vial of RhoGAM, it only covers about 30 cc's of fetal blood volume in mom. And so in our Rh-negative patients, we want to make sure that we are covering enough of the fetal blood in maternal circulation. So what are the consequences of placental abruption? Mainly fetal loss, and the other major consequence is DIC. And the reason this occurs in pregnant patients is because of the consumptive coagulopathy that can mainly happen with placental abruptions. You'll see this in a delayed abruption, or what we can call a concealed abruptions, where the placenta is sheared off of the uterus, but the blood clot is kind of still hidden behind the placenta itself. And so you're kind of having a large hematoma that's building and requiring all of that coagulation factors, but you never see the bleeding. And so because of this, you can get labs, and keep in mind that fibrinogen levels in pregnant women tend to be already a little bit higher. So anything that is below 300, you should kind of increase your index of suspicion that she might be going to DIC. And keep in mind that levels less than 50 are associated with severe bleeding, and for pregnant patients, you want a level about 100 if you're going to take this patient to surgery. So the treatment of DC, I'm not going to go into this slide is kind of detailed, but I just left it in there in case you guys wanted a copy. But keep in mind that a unit of FFP contains only about 250 to 400 milligrams of fibrinogen, and a unit of cryo is about 350 milligrams. So to raise your fibrinogen from 0 to 100 in a pregnant patient takes anywhere about 16 to 20 units of cryo or FFP. So methods to reduce blood loss. And again, this is to be done after delivery of the baby. So most of the reasons for patients to continue bleeding after delivery is atony, where the uterus just cannot contract. And so we have medical uterotonics that can be given, and then there are also surgical methods that can be used to reduce the amount of bleeding. So, routinely on our labor and delivery floors after C-sections, we always give Pitocin. We give that in a bolus, and we normally do it with rapid infusion. The side effect of that rapid infusion can be hypotension. If that does occur, normally if you slow the rate of infusion, that's going to help with your hypotensive side effects. The first choice, if you can give it, is Methergin. And the reason is it has the quickest onset of action. I'm sorry. It's 0.2 milligrams IM. You can give it up to 2 to 4 hours. Contraindicated in some patients with hypertension. And so normally in labor and delivery, we don't give it to our preeclamptic and patients that have gestational hypertension. I do find, though, that in trauma patients, they're normally bleeding, they're hypotensive, and so I will still give this anyway, because normally these patients are in pressors, and it's not going to severely affect it. But we do know that Methergin has the quickest onset of action, and if you can save fertility for that patient, then I would give it. So Hemabate is a prostaglandin. Again, it's also given IM. Contraindicated in asthmatic patients because of the side effects of bronchospasm. This is probably my least favorite to use because the onset of action takes so long. Most of these patients, it's hard to give it sublingual or oral in a trauma, and you give it rectally, but keep in mind, the rectal onset of action is super slow. So if you can give, really these are going to be your first options. And then recent data showed tranexamic acid has also helped in patients that have postpartum hemorrhage. It did not really show any increase in DVTs in this patient. So anytime an OB patient has lost about 1 liter or more, we do ask anesthesia to go ahead and give it IV. So I think we kind of are in a mixed audience here. I was thinking it was mostly surgeons, so I'll try not to dwell too much on these things. But whenever a patient is hemorrhaging, there are just some basic things that you can do as she's having her upper abdominal surveyed is a manual compression. Just uterine massage alone will stimulate the uterus to contract and hopefully decrease your bleeding. So many times what happens is that we deliver the baby, we close the hysterotomy very quickly, and then as the trauma surgeons are doing the rest of the survey, we're normally just massaging the uterus to try to get it to contract. And a lot of times this works. If not, this is a Bakri balloon. So our L&D nurses are well versed in this, but this basically looks like a very large Foley catheter. And in the trauma setting, we place this into the uterus through the hysterotomy, and the end of the catheter is actually fed through the cervix and out through the vagina. You blow it up to and what this does is it puts pressure on the placental site where most of the bleeding is occurring, and then we close the uterus. So we do normally try to close the uterus before blowing the balloon up, and the reason is as you're closing the hysterotomy, you can accidentally puncture this balloon. The nice thing about this is that you can still measure the output from the uterus because the tip of this catheter does still drain the cavity, and then if there is bleeding around it, it'll still bleed out through the vagina, so you can still assess the patient whether she's bleeding or not. And these are just kind of some surgical management ways to help with uterine atony. We call these suspender stitches. And really with this is you're putting sutures, they're normally an absorbable suture, and it compresses the uterus. And you can leave that suture in place, and it does not affect future pregnancies. The Leary uterine artery ligation, this again is more for patients that have any type of like vessel injury along the lateral edges of the uterus. I'm not going to go into too much detail of this, but basically what you're trying to do is come around the uterine artery, and traditionally you're going to go through and through the uterus from anterior to posterior. You're going to find an avascular plane within the broad ligament and come through lateral. And what that's going to do is ligate the uterine vessels. And because of all of your anastomosis, the uterine blood supply is still fine because you get a lot of anastomosis from your ovarian arteries also. So if all this fails, the hypogastric artery ligation is the next step. And I'll be honest with you, I've actually never done one of these. It's always been our oncologists that have done it or our trauma surgeons have done it because normally it requires a pretty high ligation along the hypogastric. And so the thought process is that you are ligating the anterior branch of your internal iliacs, and you want to try to do it distally to the posterior branch so that you're not affecting what the posterior branch is supplying, so the buttocks, the thigh. And because if you can ligate it right at the bifurcation of the internal iliacs, then you can really, reduce a lot of bleeding from the uterine artery. Again, I, to be honest, haven't done this. The obturator nerve is really close by. The sciatic nerves and the ureter are also within this area, so there's something to be cognizant of. I found that what happens in this case is that it's actually really hard to see when you get into this space because the patient's bleeding. The retroperitoneal space is just kind of filled with blood. And the ways that, if we ever run into a setting where we can't get this to this point, we normally just pack the patient and get them to interventional radiology to see if they can really locate where it's bleeding. So when do you do a hysterectomy? So unfortunately, this was actually a case, a patient that we took care of here in Denver Health. I don't know if some of you were around for this, but this patient had a term pregnancy. She was 38 weeks pregnant and was in a high-speed motor vehicle accident. She was actually just on her way to work, and they were chasing somebody that it was a car theft, and she got T-boned. So she was 38 weeks pregnant at that time, and when we did a fast scan, it was positive. On entry into the abdomen, the baby was extruded out of the uterus, floating in the abdomen, and if you can see this portion here, this is the left side of the uterus. She had completely avulsed her uterine artery and the cervix away from the vagina, so there was no way that we could save her uterus. This is the fundus here, and that's my hand kind of going through. You could tell that that is just, and her abdomen looked pristine, and that's just from blunt trauma and that kind of deceleration injury. So when everything has failed, you can't save the uterus, you can't put it back together. This is when you need to do a hysterectomy. The hysterectomy of choice is going to be your supracervical hysterectomy. The reason is because it's the quickest way to control your bleeding, and you remove the uterus, and it really gives you a lot more space to kind of see where she's bleeding. The reason we leave the cervix in place is because it takes more time to take the cervix out, and the top three areas of bleeding are going to be your ovarian vessels, your uterine vessels, and then at the vaginal apices. And you have a higher risk of ureteral injury during this time period because in pregnant patients, the cervix is more bulbous, and so it extends a little more laterally, which is where your ureters are coming in right at the top of the vaginal apex into the bladder. So if you can, literally leave it in place. Once you get your uterine arteries, come right, and you can ligate the top and excise the uterus and leave the cervix in place. And this normally can be done in 15 to 20 minutes. However, in the case that we talked about just earlier, we had to end up removing her cervix because she was bleeding from the vaginal apex and she had already avulsed it. So due to her anatomy, we had to remove the cervix. It does take extra time, and it increases your risk, again, of ureteral injury as you're kind of coming laterally by the uterine artery because your ureters are crossing underneath, and they're only about 2 centimeters in a non-pregnant patient. And so as the pregnancy progresses and the uterus grows, that distance closes in. But if you have to, you can save her life, and you can always call urology to put a stent in later. So I just kind of wanted to show you in case, you're ever working in a hospital where you don't have an obstetrician in place. So the two main areas when you're doing a supracervical hysterectomy is to really come across your uterovarian vessels and then again at your uterine arteries. And keep in mind, this is where the uterus and the cervix meet. And once you take that ligation, you can really just excise the uterus right on top of your ligation there, and that should take care of most of your bleeding. If all else fails, then remove the uterus. But if you had to take the patient and you have an obstetrician on the way, it's always okay if you just want to clamp right across the top of the uterus, and then you can always have your assistant hold pressure here if you don't feel comfortable doing so until you have an obstetrician there or a gynecologist. So to back it up, in most cases, hopefully you don't have to deliver the baby. But what are the indications for maternal and fetal surveillance? So either after a major or a minor trauma. So in 1981, Levine was the first to really report on a delayed abruption. And then a few years later, Higgins reported the same data. And because of these reports, it was recommended 48 hours of monitoring after trauma. However, 48 hours after majors and minor traumas, that's a lot, right? That takes a lot of resources. You can have false negatives with fetal heart tones. They're not the best at predicting fetal outcomes when it comes to category 2 tracings, which are a majority of our tracings. And so because of this, Goodwin looked at cases to see, are there certain factors that will predict fetal outcome? And so he looked at 205 consecutive cases of non-catastrophic traumas occurring during the second half of pregnancy. So he did a multiple regression analysis, and in this database showed that if you had obstetrical findings at the time of the evaluation of mom via contractions, uterine tenderness, and bleeding, that on presentation, that was highly associated with complications of about 19%. However, in their absence, the complications were super rare and less than 1%. So because of this, how long do we monitor then? What does the data show? And so Perlman and Damas reported that no abruption occurred in patients who had less than 1 contraction over 10 minutes in 4 hours. And so multiple studies were reviewed, and no one reported a delayed abruption in the first 4 hours after a trauma if there were none of these findings. So because of that, this is kind of the algorithm for fetal surveillance after a trauma. So is the fetal heart rate present? Obviously, if there is a demise, then we would manage it according to the gestational age. What is the gestational age? So this is where the viability is important. Less than 24 weeks, or non-viable pregnancies, you can really measure the fetal heart tones like you would with mom's vitals. You don't need continuous fetal heart rate tracing or contraction monitoring, as it's not necessary. And, depending on how far along we are in the pregnancy, say first trimester versus a 20-week pregnancy, you could really do it once a day versus once on admission, especially in a 10-week pregnancy. We're really not going to gain much from doing it every 4 hours with maternal vital signs. But in a 24-week gestation or more, then we know that these fetuses are viable. So we do recommend fetal heart rate and uterine contraction frequency or tracing continuously for at least 4 hours from the trauma. And so after the 4 hours, these are the things that you want to make sure are not there. So is she contracting? Any vaginal bleeding? Does she have any pain? Are her maternal vital signs stable? And is there any evidence of a coagulopathy? If any of these exist, then you're going to continue monitoring for another 24 hours. If that does not exist, then you can discontinue monitoring and overall reassure that mom and baby are going to be fine. So the delayed abruption is the major cause of fetal loss. So once maternal status improves, the fetal status will also improve. And again, the preterm birth is a major cause of neonatal morbidity and mortality. So really, if you can focus on improving maternal condition, we could possibly decrease the rates of preterm delivery associated with traumas. So again, no lab value has really ever showed consistency to be able to predict an abruption. Again, it's a clinical diagnosis. Some studies have tried to see if a Kleihar or Bakri could really predict any preterm labor, but the data has kind of been mixed, and it's really not strong enough to use. So again, the KB should be really measured in Rh-negative patients. Sorry. And coagulation profiles really only used to diagnose DIC and to help treat it. So if non-obstetrical surgery is indicated, should the fetus be monitored? So the reasoning behind, this question even is that the fetal distress might prompt immediate cesarean section. The fetus could be a sensitive monitor for how mom is doing. But the thing is, little evidence actually shows that fetal monitoring during non-obstetric surgery shows any improvement in outcomes. So because of this, the American Society of Anesthesiologists and ACOG released a statement in 2009 that says if the fetus is pre-viable, it's generally sufficient to just ascertain the fetal heart rate by Doppler before and after the procedure. So at a minimum, if the fetus is considered viable, then you want to do a non-stress test or fetal heart tracing to do it before and after the procedure, and that's what most of us do here. As long as there is, absence of any concerning contractions on the monitor. And so what's the role of intraoperative fetal monitoring? So it may be appropriate if A, the fetus is viable, you are physically able to do it, that it doesn't, by trying to monitor the fetus, it's not going to preclude your surgeons from doing what they need to do from the original procedure. And that you actually have a provider that's there that can perform a C-section if that's necessary. Because, we do know that sometimes you can have some fetal decelerations during induction of anesthesia. But most of these babies will do fine. But the thing is, if you don't have an obstetrician that is able or willing to deliver the baby, then you shouldn't be doing the fetal heart monitoring because you don't know what you're going to do with that data. And always make sure that the patient has been consented for the emergency C-section. And what we've done here is that we've always had a member of our team there during any of the major procedures that we're doing intraoperative monitoring, ready and able to do a C-section as needed. The only other thing that I would mention is that if you are doing intraoperative monitoring, then you do want to make sure that the mom has had some betamethasone or some type of steroid for fetal lung maturity in case you do have to deliver these patients early. So just to kind of review everything, the recommendations, the primary focus is mom, because as long as mom is doing well, the baby will improve. And if possible, an obstetrician should be involved early in the management of the trauma patient. And fetal monitoring is the most useful in the first 4 hours after a trauma. And the risk of fetal loss is directly related to the maternal injury severity. And so in non-catastrophic trauma, monitoring for 4 hours after the trauma is indicated if it's normal. So, and the reason why I stress after the trauma is because actually in our policy stat, we want at least 2 hours of continuous fetal monitoring that's documented. Because by the time the patients normally get over to the obstetric service for monitoring, it's already been 4 hours or more since the trauma. But as long as we have 2 hours of normal fetal monitoring without any of the obstetrical findings such as contractions, vaginal bleeding, or any type of maternal complaint, then you are okay to take the patient off and overall reassured. So no lab evaluation is necessary unless it's indicated for maternal reasons. And RhoGAM, again, should be given to all Rh negative mothers who sustained a trauma, and the KB should be sent to figure out how many vials or the dosage to give these Rh mothers or Rh negative mothers to protect their subsequent pregnancies. So here's some additional reading. I went a little bit faster just because I didn't want to go through details of surgical procedures since it's not going to apply for most of you all. But I have a more extensive bibliography. If anybody is interested, I can send it to you. But I can answer any questions or concerns, clarifications. All right. Well, thank you, everyone.